Okay, G, we'll make a start. Assalamu alaikum, everyone. Thank you for joining us for the Infections in Cancer Care session. I'm Salma Abbas. I'm an infectious diseases consultant at Shaukat Khanum Hospital. And this is a dedicated session to discuss various aspects of infections in cancer patients. We are joined by Dr. Amjad Mehboob, who is an associate professor of medicine at Bacha Khan Medical Complex. Welcome and thank you for joining us. And without further ado, we will dive into the first talk. And this is by Dr. Sana Arif. She is a transplant ID physician joining us from Duke University Medical Center, North Carolina, USA. And her talk is on fungal infections among bone marrow transplant recipients.
Good afternoon, ladies and gentlemen. My name is Sana Arif, and I'm Assistant Professor of Transplant Infectious Disease at Duke University Medical Center. I will be briefly talking about fungal infections in stem cell transplant recipients today. I don't have any financial disclosures. However, I will be talking about some drugs that are currently investigational and are in clinical trial phases. As you know, fungal infections is a very broad topic, so I will be briefly touching on the epidemiology risk factors of these infections in stem cell transplant patients and talking about some fungal diagnostics and antifungal agents that are up and coming. And so the number of stem cell transplants that are happening the world over is continuing to increase. Just in Pakistan, for example, where a couple of years ago we only had about 2 to 3 centers, now we have over a dozen centers across the country that are doing transplant, and about 806 transplants have been done in the last 2 years. The most common indications for stem cell transplant in Pakistan are aplastic anemia as well as beta thalassemia major. This is very contrasting from the population in the United States, where about roughly 20,000 stem cell transplants are being done annually. However, most of the most common indications tend to be leukemia and lymphoma. The other factor is that the patient population getting stem cell transplants and being heavily pre-treated coming into transplant is much higher in the United States. Looking at the epidemiology of fungal infections, so these are 3 studies that were done in different parts of the world. You have the TransNet study that was done in the United States. That was a consortium of 23 transplant centers, and they looked at about 16,000 stem cell transplant recipients and found an overall incidence of invasive fungal infections of about 3.4% and about 7% in allo stem cell transplant recipients. The Gitmo study, which was a prospective study done as part of a 30 transplant center consortium from Italy, looked at about 1,800 exclusively allo stem cell transplant recipients and found that they had about an incidence of 8.8%. The Caesar study done out of China in 2011 looked at about 1,400 patients and found the incidence of about 9% in their allo stem cell transplant population. Therefore, roughly an incidence of about 7 to 9%. There are various risk factors associated with invasive fungal infections, most common being the type of transplant that the patient is getting. Auto stem cells tend to have, or autologous stem cell transplants tend to have a lower incidence, like based on the TransNet data, they had an incidence of about 1.2% in comparison to the unrelated allogeneic donors, which had a rate of about 7.7%. So allos tend to have more issues in comparison to autos. The stem cell source also tends to be varied, and that can also play a part. Cord blood transplants tend to take the longest to engraft. So due to the prolonged neutropenia that's associated with it, the increased use of T-cell depleting agents, that tends to have the highest risk in comparison to peripheral blood, which tends to be comparatively lower. My understanding is at this point in Pakistan, because we do not have a nationwide registry, we're not really doing unrelated donors or cord blood transplants routinely. The conditioning regimen, whether you go for a non-myeloablative regimen or a completely myeloablative regimen, can play a part, as a non-myeloablative regimen being less intense, less likely to have issues with early infections. versus might have more issues with late infections. The type of conditioning regimen you get, the type of stem cell source you get will affect the duration of neutropenia that the patient is going to have, which directly affects the risk for invasive fungal infections. Having viral infections such as CMV can also lead to subsequent and invasive fungal infections. And more specifically, if you're just thinking about a pulmonary process, if the patient has recently had RSV, influenza, or parainfluenza, that can play a role as well. The occurrence of GVHD, which is high-grade acute, or be it chronic GVHD, as that would require patients to receive additional immunosuppression, be it in the shape of steroids or additional agents, will also increase the risk for invasive fungal infections. So it's a very complex dynamic where you're looking at how heavily treated the patient is coming into transplant, what their underlying diagnosis is, what their underlying condition is, and then the type of regimen that they get for conditioning going into transplant, the type of prophylactic agents that they receive, how long they take to engraft, and then whether they run into issues with GVHD or not. So all of these together will affect the types of infections that patients will typically encounter. And in terms of fungal infections, this is data, again, based out of the TransNet study. The most common invasive fungal infection that's encountered in stem cell transplant recipients is aspergillosis. And this is the most common species being Aspergillus fumigatus, followed by Candida. The invasive candidiasis, about 33% of the cases are caused by Candida glabrata. Yeast over here, mentioned separately, is non-candidal yeast like trichosporin, and unspecified molds include your Scedosporium, Fusarium, Cladosporium. And so the timeline of fungal infections kind of changes. So as you're going to encounter Candida, it's going to be one of the first things that is typically encountered, more so because patients are chronically colonized with Candida, and then early on have issues with like mucositis, have multiple lines, and that can lead to a higher risk for having Candida infections. This is subsequently followed by Aspergillus, and mucormycosis and Fusarium tend to occur a little bit further down the course. So this is based out of the Gitmo study that was done in Italy. And when they went and divided the timeline post-transplant, like less than 40 days being early transplant, 40 to about 100 days being late transplant, and over 100 days being very late transplant, to see if that affected the type of infections that we were encountering. And Aspergillus still was the most predominant and most common fungal infection, followed by candidal infections, and then non-Aspergillus molds, which include your Fusarium, mucormycosis, and last but not least, your non-candidal yeasts. Switching gears a little bit, and we'll talk about fungal diagnostics. And we need all the help we can get in trying to figuring out these complex cases. So 1,3-beta-D-glucan is something that has been around for quite a while. And the initial assay was the Fungitel in the United States, which is the only approved FDA assay, was approved back in 2003. However, a newer assay version of it called the Fungitel STAT assay was approved in 2020. And the basic benefit of the STAT assay is that it can be done on individual samples, so there's no batching required, meaning a faster turnaround time from the clinical microlab. Along with that, labs being with a smaller patient burden being able to do this as well. And so because the beta-D-glucan is a common cell wall component for multiple fungi, it is not always the most sensitive and specific. It's about 80% sensitivity. So the key to a beta-D-glucan is really its high negative predictive value. So it being negative is more reassuring than it being positive, because it being positive can be due to a lot of false positives as well, such as if patients had exposure to IVIG, dialysis membranes, and a host of other things. And as there are multiple different assays available across the world, the cutoffs that are used in various studies tend to be different as well. Applications of using the beta-D-glucan in fluids other than blood, such as now being used more in CSF, BAL, intra-abdominal fluid, as well, is being used. The other place is that using it in combination with other tests like molecular PCR assays or galactomannan assays can help with diagnosis as well. Speaking of molecular tests, the Aspergillus PCR, this is more commonly used in Europe, not as common in the United States. There are multiple assays that are available across multiple platforms. This is not a standardized PCR. This is something that is currently being worked on actively by a group in Europe to try to standardize the process of doing these Aspergillus PCRs. A recent Cochrane review showed a sensitivity of 79% and a specificity of 80%. Always one has to keep in mind that the results of the PCR are going to be reflective of what the characteristics of the cohort that it was being done in. What is the probability of infection in that cohort? What is the what sort of other factors come into play? And so most of this high sensitivity of about 80% is in patients who are neutropenic. So in patients that have heme malignancies but are not neutropenic, its sensitivity and specificity might be lower. Additionally, it is seen that its specificity also tends to drop in patients who are on antifungal agents that are active against Aspergillus. The other thing that's noted is that using the Aspergillus PCR in specific blood fluids, such as like if you're concerned about pulmonary infection, using it and getting it tested in the BAL sample is more sensitive than getting it tested just in blood. The other interesting thing is that the PCR assay in blood gets more affected by the use of prophylaxis, which does not seem to happen to the BAL PCR. There have been some studies looking at using this test in combinations as well. And so using the PCR being done in BAL in combination with the galactomannan in BAL with a cutoff value of more than 1 gave 100% sensitivity. Remember, using the PCR in isolation can sometimes be positive only with gut colonization and might not be reflective of true infection. The other thing is that some of these assays are very focused on Aspergillus fumigatus and are not very sensitive in picking up other species such as Aspergillus niger or Aspergillus terreus. And newer assays are also looking into their ability to pick up resistance mutations in Aspergillus. However, it is considered significant enough of a test that it has been added as a mycological criteria to the updated EORTC criteria that came out in 2020. And therefore now having 2 positive PCR samples in blood or 2 positive PCR samples in BAL fluid or 1 in either category is set to meet criteria. MALDI-TOF, which is matrix-assisted laser deabsorption ionization time-of-flight mass spectrometry, is something that, as I'm sure most of you know, has been a game changer for clinical microbiology. So it was extensively used for bacterial identification and now is also making headway of its use in the fungal world. And so this basically looks at the proteins from the unidentified organism and creates like a protein fingerprint that can then be referenced with a reference library that's available to identify the organism. However, there are multiple libraries that are currently available for fungal pathogens, and therefore this is still an area that is under development. But some of the centers that have started using it have suggested that they are noticing a better ability to identify fungal organisms to the species level. Like in one study, they showed that the sensitivity went from 78% to 98%, and the misidentification rate went down from 9.8% to 1.2%. It's used in fungal susceptibility. Testing is still very much under works. There's some preliminary data which suggests that it might be more useful for yeast than for actual susceptibility data in mold infections. Last but not least, the BioFire BCID panel. So the BCID-1 was actually approved back in 2016, but the BCID-2 was approved recently in 2020. And so this is a fully automated PCR panel with a turnaround time of about an hour that can identify correctly about 33 different pathogens, most of which are bacteria, but can identify 6 different Candida species as well, including Candida auris, and also has 10 resistance markers that it can find. Has a very good sensitivity. And so this has been very useful in stewardship endeavors across hospitals. And so once more changing over towards talking about therapeutics. And so just wanted to kind of look at this timeline for fungal infections. And as you can see, while the first fungal agents started coming out back in the 1950s, there's a huge gap after the early 2000s when the echinocandins were developed until about 2015 when isavuconazole came out. And however, there are more and more drugs that are coming down the pipeline, which is reassuring because you really do need all the help we can get with these invasive fungal infections. And so these are some of the agents that many of you might be familiar with that are currently in trial phases or early approval stages right now. Abrexafungin, which is a 1,3-beta-D glucan synthetase inhibitor. This has a slightly different site of action from the echinocandins. Rezafungin, which is a long-acting echinocandin, FMGX, which is a GWT1 protein inhibitor, and this affects the anchoring ability of the cell wall. Openconazole, which is an inhaled azole agent for activity against Aspergillus, and alorofim, which is actually in a new class of drugs that affects the pyrimidine synthetase ability of fungus by blocking the dihydroreductase enzyme. Fosmanogepix, which I prefer to call FMGX because it's a mouthful, is a GWT inhibitor, which is available as an IV as well as an oral agent. And it has a very broad spectrum of activity against Candida, Aspergillus species, including those that have azole resistance, Cryptococcus, Scedosporium, Fusarium. Its activity against mucormycosis tends to be plus minus. It has good activity against Candida auris. It has very good oral absorption and bioavailability. It does have higher MICs against Candida krusei, but has a good CNS penetration. And unfortunately, we did at Duke recently this year wind up using this agent for a number of our patients, about 4 different cases with patients with hematological malignancies who developed resistant Fusarium infections. And this was the only drug that was found to have activity against them. In a phase 2 trial that was recently done, which is a multi-center open-label single-arm global study that was conducted between 2018 to 2020, showed that while evaluating its efficacy as first-line therapy for Candida, it had a treatment success rate of about 80% and a survival of about 85%. So it looks promising, and no serious side effects were noted. Alorofim, which is from the class orotomides, has a wide spectrum of activity. It's active against Aspergillus species, including those which are azole resistant, endemic mycoses, Scedosporium, Telleromyces, Papiliomyces. However, its activity against Fusarium is dependent on the complex. So it does not have activity against the Fusarium solani complex, and no activity against Candida species, Cryptococcus, or mucormycosis species. It's available in IV and oral formulation, and the initial clinical trial seems to suggest that it might have some liver-related side effects where it can increase liver enzymes. It does have FDA breakthrough status in 2020. However, when it was formally sent to the FDA for approval, it was rejected in June of 2023, and there's been a request for additional data. There's a phase 2B study that was done that looked at about 100 cases that were treated for about 53 with Aspergillus, 17 with Leptospora prolificans, Scedosporium, cocci, and the success rate, which was defined as complete or partial response, was about 44% at day 42, with a mortality of about 14%. The OASIS trial is another trial that is currently underway and due to be completed sometime in 2024, is a randomized study to compare the efficacy of alorofim to ambisome for patients with invasive fungal Aspergillus. Abrexafungin, which is also in a separate class of its own, largely being studied more as an oral agent, does not have very good CNS penetration, but has good oral bioavailability. And its main spectrum of activity is Candida species, Aspergillus, Papiliomyces. It does not have good activity against mucor or Fusarium. And it has weak activity against Candida krusei or Candida lecitanii. It has some activity against PJP as well. This is currently available in the market, but it's only FDA approved for vulvovaginal candidiasis, but there are a bunch of studies that are ongoing, including a phase 2 study of using Abraxa in combinations with voriconazole for aspergillus infection and for using it as step-down therapy in place of fluconazole for patients with invasive candidiasis. And so the MARIO study is currently enrolling as well. Rezafungin, which is a long-acting echinocandin that needs to be only given once weekly, still an IV agent, tends to have the same spectrum of activity as the other echinocandin class. And a recent trial that was published showed that it was non-inferior to caspofungin for the treatment of invasive candidiasis. The non-inferiority margin was about 20% defined. It also has good activity against PJP. So the RESPECT trial is another trial that's ongoing, trying to find a clinical use for rezafungin more specifically. And this is looking at using it for prophylaxis in bone marrow and stem cell transplant patients, where it could provide prophylaxis not just against Candida, but also PJP and aspergillus. Ofloconazole, which is a inhaled triazole agent, doesn't have good systemic absorption and predominantly is targeting aspergillus species directly in the lung. There's really not much data about it being used for other mold active infections, and there are clinical trials underway about using it for lung transplant recipients or patients with salvage therapy for aspergillus pulmonary infections, and currently has an FDA orphan drug status. Thank you for listening. I'll await your questions and comments. These are my references.
Sana, thank you for an excellent overview of the management of fungal infections among bone marrow transplant recipients. And I would like to request all our online attendees to please keep typing in your questions in the chat box, specifically under the Q&A chat box. And with that, we will move on to our next presentation. And this is by Dr. Syed Faisal Mahmood. He is an infectious diseases physician. He is a professor of medicine, and he is joining us from the Aga Khan University. So over to Dr. Faisal Mahmood.
Everybody. So first of all, thank you very much for inviting me to present in this conference. And I'm really sorry that this time around I could not make it there physically. But nonetheless, hopefully we'll have a good discussion after this presentation. While I have no disclosure related to this particular talk, I do want to confess that this was not an easy talk to make. I think partly because the topic is really broad, but also, it was, when we talk about viruses, there are just so many viruses and so many cancers and so many cancer states that putting it all together was actually a little bit of a challenge. But jumping right into this, when we talk about cancers and viruses, it's actually a little bit of a love-hate relationship. There, as we know, that viruses themselves can cause cancers, and these are your oncogenic viruses, and these are very well known. EBV, Kaposi sarcoma, HPV, hepatitis B. There are many such oncogenic viruses. There are also some viruses which are oncolytic, and these are the ones that actually can be used in cancer chemotherapy, in treatment of cancer. Vaccinia is one of them. There's also some studies that HSV may be used as an oncolytic virus. But the viruses that we encounter more frequently in our clinical practice are those that actually infect patients who have cancer or on chemotherapy. And these are the non-oncolytic, non-oncogenic cancers. And actually, these are the ones that I'll be focusing on this talk, and really ignoring, for the most part, the oncogenic and oncolytic cancers. But before we talk about the viruses themselves, I think it's important to talk about the host, and why is it that people who have malignancies are at a higher risk of developing viral infections. So as you know, we have our two arms, the innate immunity and the adaptive immunity, and both are actually affected. For example, in the innate immunity, physical barriers are affected by mucositis from chemotherapy, by skin changes, because of radiation therapy, or even post-surgical complications. The cellular components of the innate immunity are obviously affected by neutropenia, but also by impaired monocyte and macrophage functions. And then similarly, natural killer cell function is also suppressed. On the adaptive arm, the B and cell and antibody production can be actually directly affected by hematological malignancies, which affect the B cells. And also, we may have bone marrow suppression because of neutropenia, which affects the B cell maturation. And the other arm of the adaptive immunity, the T cells, they're also affected by the lymphoid malignancies. And then again, immunosuppression, such as calcineurin inhibitors and T cell can suppress T cell function. And similarly, GVHD can also lead to some this is actually the T cell mediated attack on the host tissues, but also leads to some degree of immunosuppression. And then finally, memory cells formation are also impaired. So while these are more specific reasons why people who are on chemotherapy or who have malignancies are at a high risk of infections, or especially viral infections, there are also more broad reasons. For example, cancer itself can compromise the immune system because of solid tumors can make tumor-derived factors which evade the immune mechanisms. There's nutritional depletion, which affects both of the immunity. Some of the targeted therapies, for example, the checkpoint inhibitors and the specific immune pathway inhibitors also affect both the arms. Especially the stem cell transplant population, the conditioning will affect both arms, and also the delayed immune reconstitution can lead to these folks being prolongedly vulnerable for infections. And then finally, not to forget surgical stress. And surgical stress can lead to stress-induced hormones like steroids release, and also cytokines, which cause immune dysregulation. But so that's really to do with the hosts. But when we talk about the viruses themselves, you actually can group these viruses into three broad categories. The first ones are those which infect the lungs and the upper respiratory airways. And these are actually called the community respiratory viruses. The other group are actually those which are usually living within these individuals, and they reactivate, or they cause opportunistic infections. And the third group of viruses are those that actually come from the hospital or from the community. And these would be sort of your community or nosocomial viruses. And what we'll do in the rest of the talk is talk about each of these three categories separately, and just give a broad overview of what needs to be how we approach them, how we manage them, and a little bit of how we treat them. Obviously not in great in-depth detail, but to some degree. So let's start with the community respiratory viruses. These are also called CRV, and these are actually one of the most common viral infections that are seen in cancer patients. The infection themselves can cause morbidity and mortality, as we'll see, but also the problem is that these can cause outbreaks in the healthcare facility, and they can also delay the treatment of the primary disease. The important thing is that there's a spectrum of syndromes that occur because of these viruses, and there's also a spectrum of viruses at the same time. So we have the orthomyxoviridae, which are influenza A, B, and C, and then there's also the parainfluenza, RSV, and the human metapneumoviruses. Amongst the coronaviruses, and then obviously we're not just talking about SARS-CoV-2, but also the endemic coronaviruses and also MERS as well. The coronaviruses, like rhinovirus and enterovirus, and there are over 100 of these subtypes that can cause infections. And then the DNA viruses, the adenovirus, polyomavirus, and Boca viruses. I won't be talking a lot about these three viruses. In fact, adenovirus is a little bit different from the regular respiratory viruses, and probably deserves a talk in of itself. These can cause, as I mentioned, a variety of syndromes, but keeping in mind that the detection of virus themselves does not always mean that there is a disease happening. And in fact, symptoms may not always happen in people who have virus in their upper airways. And therefore, we actually may see asymptomatic infection. This we actually saw a lot of during the COVID time when there was a lot of COVID in the community, and we were doing a lot of asymptomatic screening, and we found SARS-CoV-2 to be positive. And the same can happen with any of the other respiratory tract infections, viruses. But on the other hand, when you talk about symptomatic disease, this ranges from upper respiratory tract infection, and that's the runny nose, stuffed sinuses, a little bit of maybe cough, or influenza-like illness. And this, or ILI, is actually a constellation of a body ache, cough, and high fever. And then finally, a lower respiratory tract infection, which is sort of a more advanced disease where you can actually see viral pneumonia. And this spectrum is actually a little bit of a progression also. And the question is that why does upper respiratory tract infection progress to a lower respiratory tract infection? And there's several risk factors, for example, older age, presence of lymphopenia, high dose total body radiation, and then co-pathogens. So co-pathogens would be, for example, concomitant CMV infection, but also keep in mind that these folks, once they get a lower respiratory tract infection, they're also more prone to develop secondary bacterial infections, which can also complicate things and lead to death. Each of these three syndromes, the asymptomatic upper respiratory tract infection and lower respiratory tract infection, also depends on the pathogen involved. So the three main ones we think about is influenza, RSV, and I've mentioned in stem cell transplants because most of the studies on RSV really is in this population. Then there's the human metapneumovirus and the parainfluenza virus. And all three of these, or four of these actually, they cause a lower respiratory tract infection about 30% of cases. And of these, the mortality is pretty high at about 25% if there's a lower respiratory tract infection. On the other hand, rhinovirus and endemic coronaviruses rarely cause a lower tract infection. There are some case reports of death, but those are really case reports. And really, these are restricted to the upper airway. And along with this, we have SARS-CoV-2 that causes COVID. And, I put a question mark here because this is really an evolving situation where over the last 3 years, a lot of people are now immune because of infections, vaccination, or both. There are new variants coming out. So it's really, and obviously, we don't have very recent data from a few months when all of this has happened. So this was an evolving situation to see where this would fall. More than likely, it'll be similar to influenza eventually. The asymptomatic column is blank, and the reason is that a lot of these, in fact, all of these also cause asymptomatic infection. But I really couldn't find any good data showing what is the rate of asymptomatic versus symptomatic for any of these infections in this particular population. There are testing available, and actually we have an antigen test for both influenza and SARS-CoV-2. The SARS-CoV-2 antigen test is readily available. It's the rapid antigen test. The influenza one is not really as rapidly available. Keep in mind that the antigen test needs to be done at least within 3 to 4 days of the symptoms. Otherwise, it will be false negative. PCR is available for all of these, and they're actually available in Pakistan as well. But unfortunately, only influenza and SARS-CoV-2 have individual PCRs. The other ones actually are grouped into a multiplex PCR, so one test which would check for all of these. But the question really is that do we need to test for any of these? And in my mind, and this is just the way I think, is that, I would only really check for influenza, RSV, and SARS-CoV-2. And the reason simply for this is that these are the only three ones for which treatment of some sort is available. And for the rest, we really don't have treatment to do it. So really, I'm a strong believer of if there's a test that you're going to do, you need to have some reason why you're going to do it. Before I move on to the test and the treatment, I do want to mention that for lower respiratory tract infections, remember, a CT scan is recommended over a chest X-ray. So if you're suspecting it, then do get a CT scan because the X-ray can miss the disease. So what treatments are available? We have IV, oral, and inhaled. And influenza, there's peramivir, there's oseltamivir, and there's zanamivir in the IV, PO, and inhaled. For RSV, we do have RSV IG immunoglobulins. Ribavirin, I put a question mark because oral ribavirin, we're not sure how well it works for RSV. And then inhaled ribavirin obviously has a good track record. For SARS-CoV-2, we have remdesivir IV, and we have Paxlovid oral, nothing really inhaled. while for the other viruses, we really don't have any other treatment options available. But more importantly, the question is what is available in Pakistan? And amongst these three routes, we really only have oseltamivir, remdesivir, and Paxlovid, and these last two are also sort of fairly hard to get. We have ribavirin, but its efficacy is plus minus, while the others, unfortunately, are not available over here. So really, options are limited in this part of the world. But why do we do directed treatment? Obviously, we would do this for anybody who comes in the time frame, which means that really, ideally, as soon as possible for all three of these. And this is to prevent complications. But the management of these CRVs goes beyond just the directed therapy. Keep in mind that for prevention, we also do mask, hand hygiene, and transmission-based precautions. And these are for all the immunocompromised folks, those who are infected, and also those who have had contact with an infected person. And then we also need to modify the primary disease management. And these ones are strong recommendations, where for allo stem cell transplant, there's evidence of CRV, or if there is an LRTI with adenovirus, you would either delay conditioning or you would reduce immunosuppression. While for the others, if there's an upper respiratory tract infection, or for any other chemotherapy with CRV, this is a conditional recommendation that you would either reduce immunosuppression or delay chemotherapy. So that's conditional. But if it's a stem cell transplant with a lower respiratory tract infection or evidence of CRV, you definitely would want to delay or reduce. Moving on to the opportunistic infections, the three main important ones are the herpes viridae, hepatitis virus reactivation, and these classic opportunistic infection viruses. I'm not going to talk about these last one in too much detail just to save time, but these are things like the JC virus or BK virus, which we can see especially in the stem cell transplant population. But of the herpes viridae, I think this is a really important group, and it really belongs. There are three families over here: the alpha, beta, and gamma. And in alpha, we have the HHV, human herpes virus 1 and 2. In beta, we have CMV and HHV6. And the gamma really are the oncogenic viruses, EBV and HHV8 or Kaposi sarcoma inducing virus. And the infection they cause, as we all know, herpes simplex causes orogenital ulcers, varicella causes chickenpox, and reactivation causes shingles. CMV causes an infectious mononucleus-like syndrome, and then various things beyond that. We'll talk about that. HHV6 can cause CNS infections when it reactivates. EBV and HHV8 cause malignancies. So HHV8 not only causes Kaposi sarcoma, but also primary effusion lymphoma and multicentric Castleman disease. But I'm going to focus on just these three of the viruses because they're the ones that cause problems in malignancy patients. And just to revise that, remember, acyclovir, valacyclovir, famciclovir, and penciclovir really only have HHV1 and 2 and VZV coverage, while the newer leteromavir and maribavir have CMV coverage, while ganciclovir, foscarnet, and cidofovir do have broad antiviral coverage for all three of these, but unfortunately, they are fairly toxic with bone marrow suppression and nephrotoxicity. But when you look at CMV itself, it is different in solid organ and hematological malignancies, because in the solid organ population, it's not very well studied. The consequences are really not very clear, and it is only related to immunosuppressives that we know of. While in the hematological condition, it is also related to the serostatus of the transplanted people. And essentially, before we talk about that, I think it's important to know a little bit of the definitions, because in CMV, primary infection essentially means somebody got a new infection. Recurrent infection means that somebody has had the infection in the past, but now has symptoms. And recurrent infections really can be two types: either reactivation, so the virus is obviously sitting in you and wakes up, or you get a new infection with a new strain. So that's a recurrent infection. The other important definition to know about is CMV infection. If we say, it generally just means that there's CMV in the blood, but CMV disease means that there's CMV in the blood and that there are also symptoms with it. And that's what we really need to avoid or actually prevent, which is CMV disease. And this is how this correlates with the level. So in CMV infection, you'll have CMV in the blood, but no symptoms. And then after a certain threshold, you'll start developing symptoms, and hence we now call the CMV disease. And this is going to come in prevention, and its importance comes in over there. So when we talk about the risk factors of CMV, especially in stem cell transplant, the serostatus of the donor and recipient is really important. A donor positive and a recipient negative actually has a low risk of CMV disease later on. While if they're both positive, there's a moderate risk. But the highest risk really is if the donor is negative and the recipient is positive. And this is really the opposite of what we see in the solid organ transplant population. If both are negative, the risk is obviously low of getting a reactivation. None of the two actually had CMV to begin with, but there is a risk of new infection in these folks. So, and apart from serostatus, acute GVHD and unrelated donor or mismatched donor are actually major risk factors for CMV disease, while older people, myeloablative conditioning, lymphopenia, and T-cell depletion are risk factors, but considered minor risk factors for CMV. And what we do is that to prevent, we do donor selection. If the recipient is negative, we'll try and find a seronegative donor and give CMV safe blood. And if the recipient is positive, we would give them prophylaxis or preventive therapy. And this, unfortunately, is a whole topic on itself. But this graph just describes this. When prophylaxis, you would give somebody treatment or therapy, antivirals post-transplant, just so that it just never reactivates. When preemptive therapy, you just monitor the viral load periodically, and if you see a slight increase, even without symptoms, you put them on therapy, preempting the fact that they will develop disease in the future. And in preemptive therapy, you usually monitor once or twice weekly, depending on how how high risk the reactivation is. You would start once the viral load copies are at 50 to 1,000, and you continue for at least 2 weeks minimum. And if the PCR is negative, you stop, and if PCR is reducing, then you change to maintenance therapy until the PCR becomes negative. With prophylaxis, letermovir is preferred, and you continue 14 weeks, but we don't have this here. So you can use valganciclovir until engraftment. The other reactivation is hepatitis B, and I just wanted to put the schema out there of the risks of Hep B reactivation. And the highest risk really is those people who are Hep B surface antigen positive, who are getting CD20 therapy or a stem cell transplant. Slightly lower are those who are getting CD52 or high-dose steroids, while those who are getting chemo without steroids but are Hep B positive have moderate risk. Moderate risk are also those who cleared the antigen but are still core antibody positive, and the are getting CD20 therapy. Low risk if the same people are getting CD52 or high-dose steroids, and very low risk if they're getting chemo without steroids. And hence, the treatment or the prevention is the same, in that you would give antivirals for the moderate to high risk, and you would monitor those with low and very low risk. And I'm just going to finish off now with the community-acquired infections. And I just put this last slide in here just so that we don't forget that along with your respiratory tract infections and your options of infections and reactivations, don't forget that we still live in a city where there are a lot of endemic infections. You can get your community respiratory viruses, but don't forget dengue may be an issue, measles, mumps, and rotavirus as well. And then blood-borne infections such as HIV, Hep B, and Hep C are not uncommon. And unfortunately, in our nosocomial with poor infection control practices, we do see patients getting this. And then finally, speaking of nosocomial infections, you can get a nosocomial-acquired CRVs, but also norovirus. And I'm going to stop over here to save some time, but I'd be happy to take some questions after this talk. Thank you.
Thank you, Dr. Faisal, for giving us an excellent overview of viral infections among cancer patients in merely 20 minutes. And up next, we have Dr. Faisal Sultan. He is the CEO and infectious diseases physician at Shaukat Khanum, and he will be giving us a talk on the challenges of treating TB in cancer patients.
Assalamu alaikum, everybody. Thank you for asking me to present. What I'm going to be talking about is also slightly all right. It's also a little bit difficult to get your head around and to put together and especially present in 20 minutes because it's not something that is cut and dried. And you have to rely a lot on data that is published in relatively smaller studies. So take everything that I say with a pinch of salt because none of this is really terribly solid, except for a few things that I might point out. So we'll be talking about the global, about the burden of disease in general, globally within Pakistan, as well as some data as to what we've seen over the last 3 decades at Shaukat Khanum, some diagnostic challenges as far as therapy or treatment are concerned, especially relating to drug interactions and organ damage, availability, and so on, and some conclusions and takeaways at the end. So the burden of disease overall, now this is not cancer, this is tuberculosis burden that we are talking about. This is 2021 data. Over 10 million cases, men, women, children, the split I'm showing. 2021, at least there was a 3.6% increase and 1.5 million deaths. So a sizable problem globally. But the other problem is that 2/3 of the cases are concentrated in 8 countries, and we happen to be one of them. And the common characteristic across most of these are that these are high population countries, and therefore the burden is high as well. But this is not all. Now, this doesn't project terribly well, but there is an intersect of TB and various things, including MDR and HIV. And this one? Yes. Okay. So what we can do, yeah. So the intersect here between TB and MDR is significant in 4 or 5 countries. And we actually figure in one of those, we are the third in that Venn diagram or in that part of the Venn diagram. So in other words, not only that we have a high burden of disease, but we are one of those countries which has a potential high burden of resistance on top. Okay, so now switching to the real topic, which is TB and cancer. So this is nearly a 50-year-old publication. And what it told us back then that the prevalence per 10,000 patients, now please notice just only a few patients, 201, a handful relatively speaking. So the prevalence per 10,000 patients was highest amongst Hodgkin's and then lower amongst solid tumors. Back then, the severity and mortality were high, was associated with steroid use, and 17% overall mortality, and then 48% in those with lymphoproliferative disorders. But this has changed with time. This is perhaps reflective of the era. This does not present very well, but this is a series of publications, and finally a publication out of MD Anderson in 2006, which showed the accumulated data over 188,000 patients in which they looked for TB, and the rate per 100,000 by the 2006 publication was only 55. It had dropped 1/6 over that time frame, reflecting essentially what had happened in the US in terms of diseases. Obviously, the numbers were higher in leukemia as well as in head and neck and lung. So we'll talk a little bit in more focus towards these 2 conditions or 3 conditions. This is another publication from 2006, and this is in children. And this was microbiologic diagnosis. So concurrent or with after cancer were 103 cases. Pulmonary formed 9 out of 10 cases. And so very often there is this overlap, whether this is because of cause or effect or a mutually symbiotic relationship, if I could call it that, or because it is diagnosed a little bit sooner because it is imaged and there is greater focus on the lungs is an open question. Within hepatic neoplasms, the rate was 200 per 100,000. And this was, please note, 40 times, 40x of the normal population. So the US population was, what it was there, it was 40 times higher here. So clearly, the risk was higher. And of course, the usual issue with foreign born and so on. Now, this is out of Taiwan. And what they did was looked at 1 million cases of cancer over 15 years, really large publication. This is, a little bit a break from the usual studies that I'll show, which are smaller. So 1 million cases, nearly 20,000 with tuberculosis, which is about 2%. So in other words, 2% of the cases over a cumulative time period, over a 15-year time period, had concurrent tuberculosis. Interesting to note, and this graph doesn't really show terribly well, but overall, the prevalence and incidence of tuberculosis in that country went down with time. But when you take the ratio of whether when you actually compare the ratio of those people with tuberculosis in the cancer subset versus the general population, that number went up. So what was going on? You have better treatment. So why? Because more latter day treatments of cancer, of course, also perhaps provide a higher risk for activation of disease or even perhaps initial disease. And that is why this ratio changed or worsened over time. So with time, the number of TB cases in the country went down, but within the cancer subset as a proportion, they went up. This was a meta-analysis done in 2017, 13 studies, again, nearly 1 million cases. And what this showed was, and I'd just like you to see this bit, the others are also important, but within children, whether with solid malignancies or with hematological malignancies, the incidence rate ratio for TB in cancer was 16. So the incidence rate ratio is the incidence in the normal population as estimated by their population studies versus the incidence in this subset and creating a ratio. So this suggests that children were at great risk for developing tuberculosis, especially when they have cancer. And if I look at the subset, perhaps even more so when they have leukemias. Now, this is an estimation of global burden. The WHO often will do these studies and they'll say, okay, fine, we have this many patients of this kind. And within this subset, out of a small study done somewhere, X percentage will have this disease. And so they multiply and you get a global burden of disease. By the way, this is how very often we get a burden of HIV, for example, in a country. So they think that the incidence, the annual incidence is 115,000. And attributable cases are in China, India, and Indonesia. Again, expected. The publication did not specifically list Pakistan, but you can be sure we'll be number 4 or 5. And the bulk of this, again, is out of the respiratory tract, which again raises the question whether this is a cause or effect. We'll talk about it in a little bit. When you look at this amongst chemotherapy recipients, you see the same pattern that the bulk of them happen while you're getting chemotherapy. And off note, very importantly, the large majority are those that actually have a positive interferon gamma release assay. In other words, sometimes we are losing the opportunity of looking for latent TB, which may get reactivated, at least in specific subsets. And I think this is one of the takeaways that I would like you to have. A publication on switching gears a little bit to children, 2008, children, 625 pediatric oncology patients, 87 got TB treatment, but had sufficient diagnosis only in 57. Again, not surprising given how TB is diagnosed. And so the bit that I would like you to focus on is that ALL, a fifth of their ALL patients actually had tuberculosis. And look at the incidence. This was 9,017 for 100,000 person years, which was 22 times the TB incidence in the population. Okay, what about us? So global is one thing and the region is one thing, but what about Pakistan? We presented this years ago. I just realized this is now even more than 2 decades old. And we had, during those 2 years, 40 people with a diagnosis of tuberculosis, 25 with a microbiologic diagnosis, and the rest through other means. Of this, now during this time, you had 4,000 cancer patients with 1,821 years of follow-up. And of these, 32 had a TB diagnosis. And so the incidence as calculated per year, per person years, was 1,757 if you looked at all cancers, and 4,133 per 100,000 if you looked at leukemias and lymphomas. And again, this was a fifth of all of the numbers. So how do you compare this? What is it in context to? The only context I could come out was employees. And so we had 8 cases. And when we calculated the incidence per 100,000, that was 678. So when you compare the 678 with the 1757 or 4133, clearly it's a few times higher. But also note that at that point, the WHO's estimate for Pakistan was 181. So even within employees, we were diagnosing relatively a larger number of TB cases, whether this was because they were healthcare workers or whether this was because we had greater focus and had better diagnostics, I can't say. But we presented this at IDSA somewhere, 99. Now, the more recent data and the more cumulative data from 2012 to the present time, it's 11 years data, and 66,000 cancer patients, 553 culture-proven cases, so about 1%, just under 1%. Diagnostic challenges. So we all know what latent TBI is or latent infection is, and this is a state of persistent immune response. In other words, they may not have overt disease. But the thing to remember is that they have viable organisms, and this balance that the body has created in keeping it at bay is dynamic. It can get tilted this way or that way because of a number of factors, and this is the thing that we need to remember. And so you have risk of recent infection, you have risk of reactivation, and 3 aspects that are relevant to this conversation are radiographic evidence of old TB with no prior treatment. So very often this gets confused because we're looking at lung cancer and other conditions, lymphoma, leukemia, and head and neck cancer. So reactivation is an important bit. You diagnose it through IGRAs these days. Hardly anyone is doing PPDs. Please don't do serologies. And there are regimens available. Please look them up. Don't need to read them. There are at least half a dozen different regimens from short to somewhat longer. The other diagnostic difficulty is in lung cancer, very often because, these diseases coexist. One may impact the other. There is thought that you see when you look at lung cancer cases, you see more TB in it. And when you follow TB, you may find more lung cancer in it. So it is a bit unclear as to how they coexist, but this is a complex or complicated relationship, if I could call it that. Chest X-rays are not specific or sensitive. So is the case with CTs. You can do radio densities, but there's enough overlap between the 2 radio densities that it's really not a useful adjunct. And PET CT, you can read all this, or you can listen to me, which is really not very useful in terms of being able to clearly distinguish. There may be some hints, but not great. So you're left with your conventional bronchoscopy and BAL. And I think given that we have gene expert and cultures and good cultures available, I think we need to use these more than we have so far. The other diagnostic dilemma, and I just mentioned is TB mastitis or granulomatous mastitis. And we see a lot of it and causes some confusion. Okay, switching to treatment challenges. Our options, availability or lack of it, and drug interactions and some other aspects. This is standard TB therapy. Almost everybody knows this. You can always look it up. But some of these drugs cause a disproportionate problem and challenge for us when treating. Because this audience is varied and has a lot of younger people as well, I would just like to remember, please don't add a single drug to a failing regimen. Please don't add a single drug to a failing regimen. This is a crucial bit, and we sometimes make this mistake. Use cultures, especially in children with likely source case, but almost in any situation in cancer, I would say use cultures. Now, the problem is that this is the list of medications that are available to us. Almost all, obviously, predictably have one side effect or the other, but 3 out of the 4 common drugs actually have hepatotoxicity, which becomes an issue when we are treating people with cancer, because very often they either have a compromised liver because of the disease itself or other hepatotoxic drugs are on board. If you look at it from the other side, which is the kind of effects and the disease associated, there is a long list. Again, these are look-up items. Don't try to remember, but just try to remember one thing, that these are there. They need to be remembered, whether this is gastrointestinal, hepatotoxicity, prolongation of the QT, myelosuppression, peripheral neuropathy, and so on. So these should be remembered as possibilities. And so the mind should be alive and awake to the idea that these will occur or can occur. The real problem that we find these days is this. we can talk about all sorts of sophistication, but the real issue is we can often not find TB medications these days. And so this is another topic, and I can only talk about it in the QA if you are interested. The other challenge sometimes is bioavailability. You have somebody who's nilperoral or who's had gastrointestinal surgery, and so you cannot really give them an oral drug until they get going. You can measure the degree of malabsorption through various tests, but the real issue is how and what principles to follow. And in this short presentation, we can only really talk about principles. This is concentration-dependent killing, not concentration-dependent time killing. You can do therapeutic monitoring if you have it. Many of these drugs have an AUC to MIC ratio, which is probably the one to look at if you can calculate that. And if you have IV formulations, I actually found this out of a Ukrainian publication. There's only one manufacturer that I could find that makes these. So this is the only sort of commercial mention I have of this kind. But unfortunately, I am not aware of any IV formulations that are available in Pakistan for TB therapy. Now, I mentioned AUC over MIC. So the thing is that if you are below a certain number, especially for pyrazinamide, you'll have a drop-off. Then again, for rifampin, if you have a AUC over MRC below a certain threshold, you will have a drop-off in terms of whether they will fail or not. And this is too busy a slide to even talk about. This publication suggested that if you are able to get IV drugs during a period of GI malabsorption, that there were some statistically significant advantages to using IV formulations. Okay, so what are the common cancers? So coming specifically to the actual treatment part, this is out of the registry that is run out of Lahore. And so you're familiar, commonest is breast amongst adults or amongst women, and Hodgkin's in children. The interaction categories that exist for TB drugs are the following: no known interaction to all the way to X, which means don't use them. But here is the problem. So commonly used chemotherapeutic drugs, this is data out of the Shaukat Khanum pharmacy, are these 13 listed out there. And of those 13, the ones in red do have interactions that are worth considering or worth bothering about. And what are those interactions? They're out there. Please we do not need to remember all these, but do remember that things like vincristine, things like doxorubicin have significant interactions which require all the way sometimes from interruption to temporary holding of the drugs and to switching therapy during that time. My advice and suggestion to all of you is when you are actually using doxorubicin, for example, or one of the vinca alkaloids, or even tamoxifen, do consult. Ask the ID service or ask the ID pharmacy service, because this is often a complicated area. And the kind of replacement that you do depends on the stage of the TB treatment you are at, and also depends on the kind of interruption that you expect. And so if it's only a 2 or a 48-hour or maybe 5-day interruption, that is still manageable in different ways, versus tamoxifen, for example, which is going to go on for years. You need to have alternate options, either for the tamoxifen or for the drug that you're using for TB. Overall, though, if you look at it in a global fashion, TB treatment during cancer therapy is safe and effective and utilizes similar principles. For lung cancer, the question whether you need to give perioperative or not, most people think that if you're given about 2 to 3 weeks of therapy, you can proceed with surgery and you use the standard regimen, no difference. Drug immune checkpoint inhibitors, I'll speak briefly about. We will skip over this one. In liver cancer, just broad guidance. If the Child-Pugh score is low, is fine, you can use at least rifampin and INH. Avoid pyrazinamide, because the add-on it gives is relatively small. If the score is between 8 and 10, you can use one hepatotoxic drug, probably rifampin. And if it's over 11, don't use any of these and find alternate options. Again, these are look-up items. You can always find them. On checkpoint inhibitors, all I would say is remember one thing: screen. Before you start, screen, because the risk is significant. And during active tuberculosis, you avoid these, get the treatment out of the way before you use. But this, again, is a decision that is to be made in consultation. Now, interaction between checkpoint inhibitors, ATT, should be considered. It's not that you cannot use it. And there are some nuances within this, which kind of checkpoint inhibitors might allow you to use TB therapy a little bit more easy. Renal failure, there are adjustments for many of these drugs. 2 or 3 of them don't require any adjustment, but others do. Again, please look up a resource. I used to love Hippocrates, but it's not available in this country anymore. So you can use Medscape or any others that you like. Let's not forget infection control. Just sitting in this talk here, I just read about a young physician who's lost his life to Crimean Congo hemorrhagic virus because of poor infection control. So before we talk about treatment, before we talk about grand diagnostics, let us at least have good infection control. People with a cough, people with what appears to be an infective source or to be at least isolated, a mask may be used, and use of protective equipment for your own staff, and fast tracking them for presumptive disease. All these are measures that are important. We do run a little program in which our ID fellows actually call all positive TB cultures, are then confirmed by them that whether the person has received or started to receive anti-TB therapy or not. And this is one of the benchmarks that we use for our own selves as effectiveness of our service. I would really say have a high index of suspicion, especially in endemic countries. Well, we are in an endemic country. Be very mindful of this in leukemia and lymphoma, because you saw the numbers, between 22 to 40 times higher incidence compared to the population. So our population incidence is massive anyway, so you can imagine how big the risk is. And do consider treatment of LTBI in children and in hematologic malignancies. And I should have added here in checkpoint inhibitors as well. So thank you for your patience. I'd like to recognize and thank so many of my colleagues. Some of those are ex-fellows who are consultants now and current fellows, and Mr. Rehan Niazi from the ID service, as well as Dr. Sumaya from microbiology, for helping me to put together much of the data and a lot of the slides and the background information. So I'll be happy to take questions now. Or, yeah, so.
Dr. Faisal, thank you for that excellent talk. We will now move on to our Q&A session. We are joined by Dr. Faisal Sultan for this, Dr. Faisal Mahmood, and Dr. Sana Arif. Dr. Sana Arif, if you can, thank you for turning on your video. Okay, so our first question, and I'm going to start with the questions that we received online first. The first question is for Dr. Faisal Mahmood, and this is about the RSV vaccine that was recently FDA approved. And if you can talk us through the role of RSV vaccine for prevention of lower respiratory tract infection among immunocompromised patients.
Thank you. So can you hear me? Just want to make sure my mic is working.
Yeah, we can hear
great.
You.
So actually, I would put this answer in perspective of what we should be doing and what we can do. Because unfortunately, as you know, vaccination and adult vaccination in Pakistan is a little bit of a black hole. So this year, for those who may need an update, there are 3 respiratory vaccines that are recommended. One is the COVID vaccine with the new variants, the influenza, which we do every year, and the RSV vaccine. Unfortunately, in Pakistan, currently we only have the influenza vaccine, and that also came a little late. We don't have the new COVID vaccine or the RSV vaccine. But however, if you do have access to the vaccines, and some of my patients do have access by traveling, there's actually, you should actually get the RSV vaccine if they have availability. So the answer is yes, please go ahead. But also you may not be able to get it.
Thank you, Dr. Faisal. And as we have Dr. Sana Arif, who has joined us from Duke, and she's here where the RSV vaccine is available. So I will throw the same question at her. Sana, if you can chime in on that.
Yeah, so the RSV vaccine, can you guys hear me okay? RSV vaccine is available here. And over here, I think the bigger challenge has been to make sure that patients take all three. So we've typically been recommending the COVID vaccine and the influenza vaccine together, as there's more data about taking them together. And with the RSV vaccine being relatively new, we're still spacing it apart by about a week from other vaccinations. However, that's probably going to change as we get more familiar with the vaccine. So far, we are routinely recommending it for cancer patients who are above the age of 60. Below the age of 60, it is still on a case-by-case basis and open to discussion between assessing a risk and benefit between the physician and the patient.
Thank you. Our second question is also for you, Dr. Sana. So in Pakistan, I mean, excellent presentation, and thank you for familiarizing us with some of the newer agents that are coming out for antifungal infections. We have major challenges with drug availability here. And recently we were not even able to get posaconazole and had to treat many patients with amphotericin in its place. We do have isavuconazole available, but we don't have any of the drugs that came into the market following that. Currently, what are your practices with regards to antifungal prophylaxis for allogeneic stem cell transplant patients, and what do you use for breakthrough infections?
So I think there's a lot of variation if you go to different centers as to what their prophylaxis practices are. At Duke, we are a center that does tend to use an anti-mold active agent. So we routinely use posaconazole as our prophylactic agent for our stem cell transplant recipients. And then subsequently, if you have issues with like QTCs or something, then you might choose isavuconazole, or if there is a pre-existing fungal infection that you're concerned about, you might modify things, but routinely we're using POSA. And then in terms of active infections, it really depends on what you think you're dealing with, and therapeutic drug monitoring plays a key role. That was the patient therapeutic when these new changes, like the most common thing we tend to encounter is pulmonary fungal infections. And so it's about looking into if they have the adequate drug level. Are you satisfied with it? They were therapeutic when this developed, that you want to switch agents, or do you just need to get a better adjusted dose of the patient? But based on that, sometimes we might switch from POSA to ISA, or might have to go to amphotericin. Routinely, we have so far not had to go to some of these newer agents, as most of them, like I said, are still IND. The only couple of cases where, like I mentioned in my presentation, we use FMGX was for Fusarium. And that was after looking at the isolate in culture and doing susceptibility testing.
Thank you. Our third question is for Dr. Faisal Sultan. And you briefly touched upon the issues that you have in patients who've had any kind of GI surgery or gastrointestinal cancer, where you anticipate issues with drug absorption. So given the current state of affairs in Pakistan, where we have patchy availability of even the first-line oral agents, what would you recommend for the management of pulmonary TB in a patient who has, let's say, who's had a GI surgery with where you anticipate issues with drug absorption or a malignant bowel obstruction?
No easy answer, really. I think you do need to use a little bit of creativity and imagination into putting together a regimen that would, get you through the period of the GI instability or the lack of or malabsorption. Assuming that this is surgical in nature and it's not permanent or quasi-permanent, there are options, from aminoglycosides, and perhaps also to use some of the oral agents, but in doses that may overpower some of the blockage that you may have. Rifampin, as you know, has provides some opportunity of actually dosing it at much higher levels, and so the therapeutic index is probably a little bit bigger than we have imagined it to be so far. That's another one that you could use in place. But generally, if you are without any IV options for standard TB drugs, or even for the second line drugs, and you have a gastrointestinal system that is not working for any set of reasons, your options will be severely limited. Your focus during this time must be to ensure that the person remains non-infective, and that you also don't underdose them. In other words, that it would be disastrous to use a single agent that is active, and very often that becomes the risk. So quinolones, aminoglycosides, and a mix and match of some of the oral agents might come to the rescue.
And maybe adding IV linezolid.
Yeah, IV linezolid is certainly one of the options.
Add-on. Yeah. Thank you. I'm now going to take questions from our attendees who are here in person. Yes, please.
Assalamu alaikum. My question is from Dr. Faisal Sultan. Could you possibly tell us about the efficacy rate of a drug through that, how we can find out through AUC and MIC? Like the standard drugs are, which has been used as temozolomide, cisplatin, and methotrexate. But it's also has a side effects. So how we can find out the efficacy rate of a drug that is very helpful in chemotherapy and it doesn't have any side effect?
So it seems to me you're asking a more generic question than tuberculosis, but that's fine. We'll talk about it. So look, the first thing that you need to have available to do any of this is the actual ability to test the drug level. If you don't have it, then this is all theoretical. Switching quickly to some of the TB meds, so we can get that message across, and then we can come to your specific question, perhaps what you are asking. Antibiotics typically work in 2 or 3 different ways as far as their kinetics or dynamics are concerned. So the classic example for beta-lactam drugs, so penicillin or even linezolid that Dr. Salma mentioned, will work with time over MIC. So they need to be above the MIC for a fairly extended time period, for much of the day. Then there are other drugs, classic example, aminoglycosides, that actually don't necessarily need to be above the MIC all day long, but need to have a good ratio of the peak to the MIC so that you are able to have a post-antibiotic effect that takes care of the time that you are below the period. So the classic example are aminoglycosides, which also, as you know, are used in TB therapy in certain circumstances. And then there is the third one, in which it's not one or the other, but really an area over the curve, under the curve over the MIC, and quinolones again are often cited as the example that you do there. The thing is that if you are out of options, your ability to have successful outcomes are better if you are able to achieve the relevant target for whichever drug you're using. But for that, you ought to be able to have the ability to measure levels. If you cannot measure levels, then you are forced to then rely on what you expect the levels to be with those kinds of doses. And you build in a little margin of safety for yourself, provided you have a therapeutic index which is good. That is why I mentioned rifampin, for example. You can actually, instead of giving 10 mg per kg, perhaps go to 20, 25 even and higher. And those numbers are safe so that you would have some comfort that you're able to perhaps get rifampin. The risk there, of course, is underdosing, and despite giving an extra dose, remaining below the level. As far as oncology products are concerned and those users are concerned, again, you are supposed to use the doses as described or as published, using a nomogram or a body surface area or weight. But for specific monitoring, unless you have the test available for a drug. So, methotrexate is the classic example. You're able to get those levels. In antibiotics, you have a bunch that you can measure levels on. So it's only useful in that particular way. Outside of that, that is more a concept to understand. And especially when you are faced with the difficulty of making a choice, okay, whether you're going to use your cancer chemotherapy at this time, or whether it is much more important to get a week or two of TB therapy in before you initiate cancer chemotherapy. So the timing and sequencing of all this. I hope I've answered your question.
Thank you, sir.
Thank you, Dr. Faisal. Dr. Sana Arif, I'm going to have you chime in on another issue. So I was at ID Week and I was attending a TB conference or a TB workshop last year, and they were really pushing for therapeutic drug monitoring for ATT. So if you can share your experience and if you guys have been doing that at Duke.
Honestly, we don't really have a lot of TB. I cannot even remember the last time I've had a TB case in a cancer patient, so it's very, very rare. And we've not been routinely doing drug monitoring. I've had a couple of patients with solid organ transplants where we've had tuberculosis, but we've not routinely been using that.
Okay, and I have another question for you as well. So the question is from one of our online attendees, and they've asked you on your experience using posaconazole or isavuconazole versus amphotericin as the upfront agent to treat mucor infection.
So we still typically don't go for using ISA or posaconazole upfront. We like to, unless you're dealing with a case where you've got really bad renal function and you're trying to preserve the kidneys, we typically go for amphotericin upfront. We try to get in at least a couple of weeks of amphotericin, get the MIC data back from the cultures, which for us is a send out to an external lab here at Duke. And then based on that, doing step down. So we routinely will not go for an azole as the primary agent. And in terms of going for step down for POSA versus ISA, in our experience, our MICs for the isolates that we've encountered, POSA tends to have better MICs than ISA. So just based on clinical experience, I will say that if I were to choose like blindly, I will usually go for POSA over ISA just because of what we've typically encountered in our hospital. I think what is also going to change is you do have the oral version of AMPHO that is under study right now, and I think that is also going to change management in the upcoming years very soon.
Thank you, Sana. And then another question for Dr. Faisal Mahmood. Dr. Faisal, we are hearing about this outbreak of Congo hemorrhagic fever in Balochistan. So one of our online attendees has a question for you, and they are asking you to weigh in on the role of vaccine for viral hemorrhagic fever.
So that's a tough question because viral hemorrhagic fever is not one disease. Of course, it's a group of diseases. What we're dealing with right now is the Crimean Congo fever. And actually, since morning, I've been trying to figure out what has happened, and it seems like this is an outbreak that happened within the hospital, probably because of IPC issues that happened over there. So as you know, there is no vaccine for Crimean Congo hemorrhagic fever in humans. There may be an animal one, but not a human one. So there is no role for vaccination, but there is a strong role of infection prevention and control. So any blood and body fluid exposure, if you suspect Crimean Congo, then you have to use the appropriate PPE. And then obviously once an exposure has occurred, because invariably it does, you don't always know what people are coming in with, to have a system where you can give prophylaxis if required and early detection. So I think the focus should be more on these administrative boring things as opposed to vaccines for Crimean Congo.
Thank you, Dr. Faisal. Any other questions? Yes.
Assalamu alaikum. My question is for Dr. Faisal Sultan. For patients who have simultaneous diagnosis of tuberculosis and a cancer that would need surgery, in those patients, does ATT ever, for example, if the patient is frail, does the timing of surgery ever changes because of the ATT to make the patient a little bit more stable for surgery and for the anesthesia stress? The second question is there any recommendation for a perioperative hold of the ATT because of the toxicity of ATT in patients who need surgery for cancer?
So two things. First, unless your surgical intervention is acute and is required, which obviously will take precedence. Other than that, if you can actually wait for 2 weeks for the anti-TB therapy to get in and get going, that would be the preferred option. Obviously, you need to weigh in all sorts of things. So if it is a solid tumor, if it's a mastectomy or a lumpectomy that you need to do, 2 weeks is certainly, the right thing to do. At 2 or 3, I would say, before you go in for surgery. Obviously, in circumstances where you do not have that choice, well, then you go ahead. The second thing that you asked is a little bit harder, in which the duration and type of interruption that is palatable. Well, actually, not even a day is palatable, to be perfectly honest. And so I think ideally, one ought to be able to continue TB coverage, perhaps with parenteral agents, as we've talked about, the 2 or 3 that are available to us, ideally 3, not less than that. But much depends also on the stage at which you are as far as the tuberculosis is concerned. Early on, you will have a disease that is multibacillary or will have a lot of bacteria to kill or cover. So the stoppages are riskier. But at a later stage, after the first maybe 6 to 8 weeks, a short interruption may not be as hazardous or as risky. It's always like in most things, it's always a balance between one risk versus the other. Ideally, if you could have parenteral antibiotics for all the first line, that might help. As I mentioned, this Ukrainian company seems to make it. I actually did not, I couldn't get too much detail beyond just their name and the fact. And the publication I noticed was also Ukrainian. So it's clearly a regional phenomenon. How good they are, how stable they are, how they've been studied, I really don't know. In a global context, not too many of these are available in an IV formulation. But as you just heard Dr. Sana mention, sometimes what we assume to be necessarily just an IV drug or just an oral drug sometimes challenges our assumptions. In the passing, I don't know if you noticed, she said amphotericin, oral. And so we've always only used IV amphotericin. So there is this new oral option perhaps around the corner that might change things. So it is possible that the IV options do exist. The problem is that their use is niche. In 99.9% of circumstances, you only need an oral anti-TB drug. And for those special circumstances that you are challenged with, or we are, the commercial, even if scientifically, technically, the drug is doable, it may not be available because it does not meet the business needs of the manufacturer, and therefore they're not available. So you have to use a little bit of imagination and a mix and match. But the one thing that I'll still reinforce for you is that don't underdose. If the choice is between a very short interruption, and just, you can give one drug, no, please don't. Just let a 2-day interruption happen and resume once they are not nil by mouth. Yes, please.
So, Salma, I will just add to this.
Oh, yeah. Yes, Dr. Amjad, please.
I mean, this question will become very tricky if this is an MDR TB.
Oh.
I mean, you have actually to calculate the risks to not just to the patient, to the environment, and to the people who are treating. So priority setup actually is like to make all of them into the equation.
Yep. Thank you for pointing that out.
Yeah, and second thing is, again, this TDM that sir is quoting repeatedly. I will just quote an example. I've seen my first patient in US who was on rifampicin 1200 mg. It was my first case. I have seen a patient on RIF 1200 mg OD. I have never seen these TDM charts and things like this. And I asked the treating doctor. And then I've seen these TDM charts in routine. So, I mean, this is a specific population who is at risk. Cancer patients are very different. We have not touched upon the MDR in cancer patients. I mean, this is an area. But TDM for any at risk or high risk or immunocompromised population to monitor their drug levels is very important, not just in TB. Even this voriconazole and antifungals are now very much under this TDM. So we should not miss on them, and we should be, we do have a window to go up. So better go up rather than underdosing. And for gaps, I mean, we should not miss the basics. A smear, a repeated smear, as per the national guidelines, our protocols. We have gene experts everywhere. We have gene expert ultra now available to us in many centers. So go back to the diagnosis again and again. You can label someone with that modalities, and the importance of sensitivity testing in immunocompromised population compared to general population is very important. I mean, every patient who is coming with TB in cancer population, in my opinion, I will not spare them without sending a sample for sensitivity, because this is a tricky area again. MICs are not reported in our systems for ATT, but at least we do have a rough estimated sensitive report.
One other thing that's important for rifampin, and again, I'm just touched on it, but I want to stress so that we know. The original dose ranging studies for rifampin never looked at upper doses. The moment they found a dose that was effective, they stopped. Rifampin was worth an arm and a leg. It was the price of gold, essentially, when it came about. So the whole focus was on finding the minimally effective dose, and that was the 10 mg per kg, and that has really become the norm and standard. Now there is this idea of actually using up to 20 or 30 or 35 mg per kg. And we did also recently have a publication which talks about safety, at least, of such doses without compromising anything. Of course, efficacy is another question that has to be determined still. So when in doubt, as I said, for almost all of these, dose on the higher end of Novalin and rifampin, at least from published data, you have a fair bit of comfort and confidence that you can go higher rather than being on the lower end. But again, I'll stress again, don't leave rifampin alone. Okay, it must be accompanied by a friend, at least one or two.
My question is from Dr. Faisal. Sir, what are the indications to treat a patient with LTBI? And if there is an indication, how to proceed? Do we need to follow that patient after completing the treatment?
So in a low incidence country, LTBI must be treated, full stop, right? No question. Everybody should, almost everybody should. The only exceptions to this would be those with significant liver disease where the risk-benefit ratio would be against treating LTBI, especially in older people. So as you get older, your risk of the remaining number of expected life years in which you will activate are fewer. And if you have a liver that has a child score which is higher than a certain number, obviously you know certainly not over 11. Now, this is always a challenge in a high incidence country, because then good 30-40% of the population becomes eligible for treatment, if one were to believe some of the numbers. About 20% of 20-year-olds in high incidence countries will have a positive TB skin test or IGRA. About 50% of 50-year-olds and about 60-70% of people above that age. So here you have to really pick and choose. So as I mentioned, those that are particular risk, either of recent exposure, so recent new disease, or those that you think will reactivate, the list that I showed, people with diabetes, with cancer, with silicosis, with chronic lung diseases, with, congestive heart failure. So there's a long list of diseases that will tilt the decision in favor of actually doing. In fact, the thought is that one of the biggest challenges that remains in terms of being able to eradicate tuberculosis out of the world is actually LTBI. And if you were able to do effective LTBI therapy, or it's called tuberculosis infection now, you would have a jump start on reaching your TB eradication goals globally. So even national programs now are focusing on using LTBI. So on the whole, if you find it, treat it.
This is what the national program says.
That's right.
Rifampicin is now available, and the weekly schedule is not available to us. So it's for all this time in the country.
Yeah.
Assalamualaikum. I have a question from Dr. Faisal Mahmood. Can he hear me?
Dr. Faisal,
Yeah, I
can
can
you
hear
hear
you,
us?
Jamshed.
Thank you. And thank you for the lovely talk. I always enjoy your talk. So recently I saw my breast patient who were also having HIV, which were also HIV positive. And one of the patient was in visceral crisis as well. So we have good ID team here, and the patient was also having high viral load as well. So, but I would be interested in your thoughts and how would you proceed with in this scenario, the patient with high viral load along with the high disease burden. So, what would be your recommendation to an oncologist? Thank you.
Thank you. So high viral load, high HIV viral load?
Yeah. HIV.
So I would actually treat both concomitantly. So if you have somebody who's diagnosed with the malignancy and HIV at the same time, you would just treat both at the same time. Really, I wouldn't, and over here, normally I have a conversation then with our oncologists in that how urgent it is to start chemotherapy. And if they say that chemotherapy needs to start urgently, then you just do both together. I wouldn't delay one or the other. I'm not aware of a lot of IRIS with HIV and malignancies. There certainly can be some with Kaposi sarcoma. I've seen that a few times, but I think just concomitant treatment of both at the same time. Viral load would be high in somebody who's not on HIV therapy as yet before therapy started. So the viral load is immaterial. I do want to add one thing to what Amjad said, is that Amjad does mention that Gene Expert Plus is positive and Rifampicin is positive, is available. Just to keep in mind that this is not so in most of the country. So, so for example, we, even though being a TB center, have access to neither, and many TB centers in our province don't as yet. So.
Yeah, in our hospital, we often have patients who test positive for HIV on their pre-chemo checks. And in our practice as well, we treat both concomitantly. Do you have any other questions? Yes? Yeah.
Assalamu alaikum. मेरा क्वेश्चन डॉक्टर फैसल सुल्तान से है सर. थैंक यू सो मच. इतना बड़ा इवेंट आप लोगों ने किया पेशावर में, और रिसर्चर्स को, प्रैक्टिशनर्स को और स्टूडेंट्स को भी मौका मिला कि यहाँ से वो फ़ायदा उठाएं. लेकिन मेरा गिला है केपी के मेडिकल प्रोफेशनल से कि उन्होंने जो इससे फ़ायदा उठा सकते थे लोगों ने पार्टिसिपेट नहीं किया. रीज़न कोई भी हो सकती है, लेकिन मैंने ये महसूस किया कि कम से कम लोग शरीक हुए, ज़्यादा फ़ायदा इससे उठाया जा सकता था. सर क्वेश्चन कमिंग टू डॉक्टर फैसल सुल्तान है मेरा क्वेश्चन. वो ये है सर कि आपने गो के टॉपिक आपका था टीबी रिलेटेड टू कैंसर पेशेंट्स, लेकिन हमारी कम्युनिटी में अदर देन कैंसर पेशेंट्स भी बहुत सारी टीबी पेशेंट्स में है. ऑल्दो के जी कैंसर पेशेंट्स तो ज़्यादा रेगुलरली चेकअप्स भी होते हैं उनके, लिहाजा आप उनको डायग्नोज भी कर पाते हैं और ट्रीटमेंट भी होता है. अच्छा, जो दूसरी कम्युनिटी है सर, नॉन कैंसर पेशेंट जो है हमारे, डायग्नोसिस प्रॉपर नहीं हो पा रहा, और सर जो डायग्नोसिस है प्रॉपर ट्रीटमेंट नहीं हो पा रहा. जो पेशेंट्स हैं सर उनकी प्रॉपर ट्रीटमेंट ना होने की वजह से रीएक्टिवेट भी होती है डिजीज़. लेकिन बाकी कम्युनिटी को उन पेशेंट से बचाने के लिए मेन के जी जो ट्रांसफ़र ऑफ डिजीज़ है फ्रॉम पेशेंट टू हेल्दी मेंबर्स ऑफ द सोसाइटी, उसके लिए कोई मैस कैंपेन की ज़रूरत है, जिस तरह के पिंक रिबन कैंपेन एक्चुअली पूरे पाकिस्तान में वर्ल्ड वाइड हो रही है. तो क्या पाकिस्तान में इस तरह का कोई आप सजेस्ट करेंगे या गवर्नमेंट को रिकमेंड करेंगे ताकि उस लेवल पे ये चीज़ हो जाए?
Talk better about it, but your national TB program है ना, and the provincial TB programs actually have many of the steps in there that ought to sort this. उसमें timely initiation of therapy है, उसमें contact tracing है, उसमें LTBI का treatment है, ये सारी चीजें मौजूद हैं. So really it's not a question of science. It's really a question of using your existing resources to do what they're supposed to do. अब COVID के अंदर आप contact tracing करते थे ना, ठीक है ना? It helped. Does it help in 100%? No, you can't, because obviously all these public health measures or interventions have a certain efficacy rate. But when you look at the larger picture, फर्क पड़ना शुरू हो जाता है, बीमारी कम होना शुरू हो जाती है. TB का जो burden है in the West actually started to go down even before necessarily there were effective TB drugs. उसमें और बहुत सी चीजें हैं जिनका ताल्लुक housing से है, aeration से है, education से है, nutrition से है, God knows. So all those things are there. It just needs to be done. And remember, it can be done. I'll use a COVID example that I do all the time, that when we were starting out with COVID vaccination, a lot of people in the system thought, how will this country's system vaccinate 200,000 COVID doses a day, right? And on peak day, 2.3 million were done. Not 200,000, 2.3 million, 10 times as much. And so it was the same people doing it. It was the same vaccinators, the same health system. They were better aligned, they were incentivized, and they were focused. And obviously it helped that there was a disease that caught the imagination of the world. But in any case, it was the normal public health system that reacted. So this is the opportunity is there. I think one great thing that has happened, which we are not paying too much attention to, is the availability, although patchy, Faisal Mahmood said yes, but the availability of GeneXpert. I think it'll certainly help in earlier diagnosis. The other thing that is gently making a change, but it should be more, is use of cultures. We do not use it as much as we should for TB, and the availability of a culture and then therefore a sensitivity from a good lab makes your life easy when it comes to treating and then therefore preventing further spread. So all of these are more commitment steps than or political commitment steps than the science part. About people not coming, well, they always come. It starts slow, but it builds up. So don't worry. If you keep doing these, more people will utilize these sessions. Thank you.
I think one of the important thing is ownership. There are systems, but if I ask everyone in this room, how many of you are reporting your TB patients? I mean, this is an important component to report each and every TB patient to the TB program, because they have their qualified pharmacists, they have psychologists, they have a response team to go to the area from where this patient is coming. Just a week ago or 2 weeks ago, I've seen a patient from a madrasa, female patient. And all of a sudden, I've seen another patient from the same madrasa. Now it is my responsibility to inform the TB control program. I have sent them a voice message that this is a sensitive area because people may take it other way. And my message was shared with the owner or who was running that madrasa, that this is an important message for your students and this is for the safety of your students. And then a camp was arranged with them, like X-rays and everything is done. So this is something done in routine in public sector, but we mostly are not clear or aware about it. So the responsibility lies with us. If we get a positive, report them properly to the relevant authorities and they do respond.
Yep. Thank you, Dr. Amjad. I have another question for Dr. Faisal, and this is from one of our online attendees, Dr. Faisal Sultan, since we have two of you. So they want to know if you would recommend routine screening for latent TB infection prior to starting chemotherapy, and if so, for which cancers?
So if I remain true and honest to what I've said, the answer is yes. The only difficulty, of course, is the logistics of it. But yeah, I think that we are underutilizing the opportunity of LTBI testing and initiation of therapy, at least in high-risk cancers.
I think we are done with the time.
Yep.
Dr. Salma, I think we are done with the time.
We actually do have 15 minutes, but I think we are going to wrap it up here. Thank you all for joining us, and it was a pleasure to have you, and enjoy the rest of your day. Thank you. And a big thanks to our speakers, especially Dr. Faisal Mahmood and Sana Arif, who've joined us, and especially Sana joining us at 4 a.m. Thank you so much, both of you. Thank you. Allah Hafiz.